Good morning, everyone. Hope I am audible now. And can you see my screen? Poonam, can you hear me?
Yes, I can hear you, Dr. Kannan. Your screen is visible.
And my screen is also seen? Okay, great.
Yes, please.
Okay, thank you, Dr. Poonam and the ACTRAC team for having me here. And sorry for the technical glitches. So most of us do thyroid surgeries. Sternotomy is an integral part and an important armamentarium which every thyroid surgeon should have. At least we should be prepared and we should anticipate when we need a sternotomy in a patient whom we are doing thyroidectomy. So today we will discuss about what are all the indications for thyroidectomy and what are all the challenges and how do we overcome that. So hope my screen is moving. Dr. Poonam?
Yes, it is moving, Dr. Kannan. Yeah, please.
Okay, great. Thank you. So when we need sternotomy in a patient with thyroid lesions, so when you have a retro-sternal goiter, when you have a lymph node in the mediastinum, for example, particularly level 2A, 2B, and level 2 right and level 2 left of the mediastinal nodes, which cannot be cleared by VATS, that's where normally the thyroid malignancy is metastasized. And if it is not approachable from the neck, we would need a sternotomy. But the most important indication is vascular control. For example, when you have a patient like this who has a thrombus inside the internal jugular vein going up to the brachiocephalic vein, most of the times the thrombus can be milked out and you can safely remove, you can make a nick in the IJV, gradually milk out the thrombus and most of the thrombus comes out. But the most important danger is the thrombus can get dislodged and it can get into the right atrium, it can get into the atrium and choke it. Once it is choked, then it becomes an emergency. You have to evacuate the clot and do such things. So this patient, when we did a sternotomy, here you could see the brachiocephalic vein, here you could see the internal jugular vein and the thrombus inside it. This is the main tumor. This is the next specimen, level 5 nodes, and this is the thrombus inside the internal jugular vein going up to the brachiocephalic vein. So whenever you operate a patient with the thrombus inside the internal jugular vein going up to the brachiocephalic vein, identify the lower limit of the thrombus. If the thrombus is only up to the lower end of the internal jugular vein, you can do a claviculotomy, get a distal control. But if it is progressing further, we always do a sternotomy. We always keep the internal the insertion, the brachiocephalic vein exposed, and we get below the lower end of the thrombus. And in most of the cases, we do have a cardiopulmonary bypass ready in case the thrombus migrates and the patient goes into bypass so that we have time to salvage the patient. So whenever you have a patient with thrombus extending inside the vein, always be careful. It's a need for sternotomy. Always have a vascular and a thoracic surgeon with you. Now, the other most commonest reason why we do sternotomy is retro-sternal goiters. About 80% of the retro-sternal goiters will come from the neck. So before getting into detail with retro-sternal goiter, we'll know what retro-sternal goiter is first. And there were various definitions given in the literature. So if the greatest dimension of the lesion inside the thorax, you do an X-ray, the lesion of you could see the retro-sternal goiter in the thorax in the X-ray. If the lesion is bigger than what is in the neck, it's a component for retro-sternal goiter. If you have a lesion which is going according to Kreil, if the lesion goes up to aortic arch, it's a retro-sternal goiter. When you do a scan, if the lesion goes up to T4 vertebra, it is retro-sternal goiter. According to Wang, if the 50% of the mass is in the thoracic inlet, it's a retro-sternal goiter. There are various definitions and there are various classifications also. These classifications help us in planning the surgery. For example, if the 50% of the component is in the neck, or more than 50% is in the neck, and little bit is in the chest, or substernal goiter. If more than 50% is in the chest, it is partial intrathoracic. If it is more than 80% in the chest, then it is complete intrathoracic. If you have a complete intrathoracic...
Sorry, Dr. Kannan. Please, everyone mute yourself, please. And IT, please make me co-host. Please, everyone mute themselves, please. Sorry, Dr. Kannan, please go ahead.
No. Thank you, Dr. Poonam. Okay, so when you have a lesion which is 80% inside the thorax, what you need to know is what is the greatest dimension of the retro-sternal goiter in the chest, and what is the length, what is the diameter of the thoracic inlet. If it is going to be bigger than this, no way you're going to get it out from the neck. So that meets the sternotomy. Similarly, you also grade them depending upon the percentage of the lesion which is inside the chest. It's graded between 0 to 25, 25 to 50%. If it is more than 75%, always be ready with a sternotomy. This is the classification which we normally follow. So it's from type 1 to 3. So whenever you have a retro-sternal goiter which has no attachment to the thyroid in the neck, it is an isolated mediastinal goiter, which is quite rare. And this is the only goiter which gets blood supply from the thorax. If it gets blood supply from the thorax, then it needs a sternotomy for vascular control. And type 1, this is most common. More than 85% of our lesions would be from the thorax, from the anterior mediastinal. So if it is in the anterior...
We are going to make any progress, then it has to be to accept what the others have done and move ahead on that and do some more.
ITD can help.
Hello, IT, please, can you mute Dr. Devraj? Hello, IT? Or can you make me co-host? Is there anybody in IT? Ashwini, anybody?
Yeah, thanks, Dr. Devraj. Thanks for muting yourself. So, okay, so let's proceed. So if it is type 1, it's in the anterior mediastinum. It's the simplest of the retro-sternal goiters. You have you have the great vessels posterior to it, trachea, recurrent posterior to it. Most of them would come out from the neck. And what are all the difficulties? We'll go to it later. If the lesion is in the posterior mediastinum, you'll have the recurrent laryngeal nerve, trachea. When you start the surgery, you'll have all the great vessels in trachea and recurrent laryngeal in front of you. Most of it would need a sternotomy. The extension can go behind the esophagus, or the extension can go between the trachea and the esophagus. So if it goes between the trachea and the esophagus, then it's an even more indication for a sternotomy. So type 2, type 3, be prepared for a sternotomy. Type 1, when we need to be prepared, we'll discuss it as we progress. So how common is retro-sternal goiter? This depends upon the referral bias and the institutes where you work. In our practice, we would have at least 10 to 20% of our thyroidectomies would be retro-sternal. So on an average, literature-wise, it's somewhere between 10 to 20%. So this we have discussed before. Primary intrathoracic retro-sternal goiter, which doesn't have a communication from the neck, and the blood supply is from the thoracic region. So it would need a sternotomy. The 99% of our lesions would be secondary. It extends from the cervical neck into the chest. It can either go into anterior or posterior mediastinum, anterior being common. What's the reason for primary? It is embryonal rest, or you have to identify. Most of them would be present in the thyrothymic ligament, which enlarges and causes the retro-sternal goiter. Why does the retro-sternal goiter occurs? When we look at the thyroid anatomy, it is closely wrapped by the strap muscles anteriorly, vertebra posteriorly. Superiorly, the strap muscle attachment to the thyroid cartilage prevents the extension, and to the hyoid prevents the extension anteriorly. And so similarly, below you have an open space where, because of the effects of swallowing, as the food migrates down, because of the effects of swallowing, there will be a downward extension. The respiratory dynamics start sucking in, which creates the negative pressure in the thorax, which promotes downward growth of the thyroid lesions, and even the gravitational force. So the superior part is quite covered, the inferior part is a bit open. That's why the lesion could migrate down. Most of the patient present with obstructive symptoms, usually dyspnea, stridor, cough. Very rarely they'll complain of dysphagia or lumps in the throat. When you have an infiltrative lesion, or if the lesion is compressing on to the superior vena cava, we'll have Pemberton syndrome or superior vena cava obstruction, which we will go to it. If it is an infiltrative lesion, it can cause hoarseness of voice because of vocal cord paralysis, Horner's syndrome, etc. And depending upon whether it is functional or not, other problems can happen. So neck mass, pressure symptoms are the most commonest symptoms. Dysphagia, dyspnea, hoarseness can happen. Stridor or breathing difficulty can happen if there is tracheomalacia or there is external compression or the lesion is infiltrating into the trachea. If the lesion is infiltrating into the trachea or if there is external compression which is causing significant narrowing of the trachea, more than 90%, we have to anticipate difficulty during induction of the patients. We'll go to it as we progress. This is important, Pemberton sign. Once the patient raises her hand above the neck, the thoracic inlet gets choked. So there is compression of the superior vena cava, will get dilatation of veins. Patients will develop breathing difficulties. These patients needs to be planned well. The thyroid cock needs to be delivered safely. So plan these patients well. Don't just try to pull them out from the neck. If needed, be liberal with doing a sternotomy. Most of the lesions are not malignant in a retro-sternal goiter because malignant lesions are infiltrated. They tend to infiltrate straps and spread in the neck. But we do have a quite share of patients. In our series, we would have at least 5% of these patients with retro-sternal extension might be malignant. And if you have a malignant lesion with retro-sternal extension, always be prepared for a sternotomy. So most of the cases of retro-sternal goiter, if it is big enough, you would be seeing them in the chest X-ray. You'll be seeing them in the chest X-ray. The most important sign you see in the chest X-ray is you look for tracheal displacement. The displacement of the trachea is the one which, displacement of the trachea is the first sign which you could see. And you could also see the calcification around the benign lesions. And the soft tissue mass is also well appreciated in the chest. So you calculate the maximum diameter of the lesion in the chest and you calculate the diameter of the thoracic inlet, which would help you plan the surgery better. But nowadays, the most important investigation is contrast enhanced CT scan that will tell us about the plane between the lesion and the mediastinum, relationship with the greater vessels, and it also will give us idea whether the lesion is malignant or not. And this will help us plan the surgery much better. Never operate a patient with retro-sternal goiter without a CT scan, which gives you much valuable information so you can avoid surprises during surgery. So this is a patient, you could see the gross shift of the trachea, which would help the anesthetist in planning. You could see the luminal narrowing is that it's just 50% narrowed. If the narrowing is more than 90%, you also need to plan for intubation. And so here you see the lesion going below the aortic arch. If the lesion is going below the aortic arch, the need for sternotomy might increase. So plan yourself well. So should we operate the patient with retro-sternal goiter? Yes, all the patients with retro-sternal goiter itself is an indication for surgery. Why? Because there will be a natural progression of the disease. Ultimately, they'll land up in pressure effects, and you can prevent an upper airway. You can prevent an airway compromise later, which becomes very difficult to manage. And you can't rule out malignancy in these patients because targeting FNAC intrathoracic is difficult. And now with advances in the surgical techniques, anesthesia techniques, and thoracic backup, so this is very less morbid and recovery is also much better. So always patient who is fit would need a excision, either cervical or thoracic. So as we discussed before, how do we remove the retro-sternal goiters? Most of them will come out from the neck. So cervical approach, 80% would come out from the neck. Some of them would need a partial or complete sternotomy. Partial sternotomy is a sternal split in which you split the manubrium up to the third ring and then just open this would be anterior mediastinum. This partial sternal split is for the lesions which is going into the anterior mediastinum, type 1. If type 2, type 3, most of the times would need a sternotomy, or if it is extending into the other components, might need a posterolateral thoracotomy. Just if you need a vascular control in such cases on the brachiocephalic vein, and in such cases, you can do a claviculotomy. So this is how we would normally start a patient with a retro-sternal extension in our practice. We have a thoracic surgeon backup. we prepare the patient for sternotomy. The patient should be fit for a sternotomy. This is the preliminary thing. Once then we do a normal collar incision, we tend to cut the strap muscles at the lower end, and all the other steps of thyroidectomy is normally done. We ligate the middle thyroid vein. We handle the superior pedicle first. We identify the recurrent laryngeal nerve. The thyroid is attached mainly at the ligament of Berry. That's the main important point of attachment. We would prefer to disconnect the thyroid attachment onto the Berry so that the thyroid gets mobile in that area. Then we handle all the vasculature in the neck, inferior thyroid vein, the smaller pedicles of inferior thyroid artery. Everything is handled first. Then we get into the suprasternal notch. I see to that it's not going posterior. Recurrent laryngeal nerve is preserved. Then you get into the plane between the tumor and the sternoclavicular joint and gently go substernal. By this finger dissection, you can gently remove this tumor. Once the tumor is completely out into the neck, the routine surgery is completed. There will be a dead space. All these patients you must keep a drain. In few small thyroids, we need not keep a drain. When small thyroids in the neck, you can avoid thinking of a drain, but there will be a huge dead space. To close the dead space, always keep a suction drain. Sometimes you might not have an adequate space. In such cases, you can do the opposite lobe. If the opposite lobe is also booked, if you do the opposite lobe, you have some space to move around. And in some patients, we can put a stitches, gently start pulling it out. Once it starts coming, you can gently start putting stitches one by one. And there are various other techniques described. If by gentle finger dissection, if the lesion is not coming, be prepared for a mediastinal approach. What are all the mediastinal approach we have? The commonly done is midline sternotomy or median sternotomy, or if it's just an anterior mediastinal tumor not extending much below, or if the lesion is above the arch of aorta, then you can do a small minimal upper sternal split, or rarely you can do a manubriotomy. Mediastinoscopy is usually for lymph nodes, not for retro-sternal goiters. Rarely, if it's in an uncommon location, VATS can help. Can even help us in avoiding a sternotomy. So usually lesion which is going up to the aortic knuckle, you have to be prepared for a sternotomy. Give an initial attempt. If it's not possible, then go ahead with the sternotomy. So can we anticipate the need for sternotomy preoperatively? Yes. There were various studies on it, but on an average, if you have a patient who gives a history of thyroid cancers, thyroid lesion with retro-sternal extension, more than 13 years, then you must be prepared for a sternotomy. If there is a recurrent goiter, you must be prepared for a sternotomy. You look at the thyroid density, more denser thyroid tumors doesn't slip out easily through the neck. So be prepared for a thyroidectomy. The thyroid density can be calculated with the CT scan. So if there is gross subcarinal extension, and if there is involvement of more than one compartment in the mediastinum, then it becomes difficult to handle from the neck. So when you read a CT scan, look for an ectopic, if there is an ectopic nodule, if there is a dumbbell-shaped goiter, and if there is a conical goiter, which is the tip pointing into the thoracic inlet, and the conical part is up in the down in the thorax, then it becomes difficult to remove it from the neck. So if a lesion is below the arch of aorta, recurrent goiters, more than 260 grams inside the chest, and if there is more than one mediastinal compartment involvement, or if there is an iceberg effect, then you must be prepared for a sternotomy. If it is extending posterior to the pleura, and there are multiple components in the goiter, always be prepared for a sternotomy, which is quite important. So there are times in which the compression is more than 80 to 90%. In such cases, intubation might be difficult. Securing the airway might be difficult. Tracheostomy with the retro-sternal goiter in situ sometimes becomes difficult. So plan these patients well. We had 1 or 2 patients in which we started the surgery with ECMO. Then we exposed the trachea well. Then we identified the component where it is collapsing. Then we did a tracheostomy. Then we completed the surgery. So planning the surgery when there is tracheal compression is quite critical. So this is what I was talking about, a mini sternotomy. You just cut the manubrium sterni and the third intercostal, so that you get a space to expose your anterior mediastinal. So this is a complete sternotomy, which we would do normally. You do a sternal split, expose it, achieve hemostasis at the sternal cut end. When you close it back, you put in wires and close it back. So this is normally done during a thoracic or any thoracic surgeries. We usually have a thoracic team with us when we do a sternotomy. So when we do a sternotomy, we identify the recurrent laryngeal from top. Then once you do a sternotomy, the entire surgery becomes quite simple. You have adequate space to handle, and you look for any vascularity from the thorax, control those vascularity if at all something is there, or else it just slips out. Then most of these patients would need an ICD, and most of these patients would need an intrathoracic drain, and then that's what we normally. Sorry, and I couldn't play my video. There is some technical glitches. So these patients would have a very good prognosis. So the symptoms nowadays, with the advances in the anesthesia techniques and with the advances in the surgical techniques, and these thoracic surgeries have become quite safer. Rather than putting in the finger from the neck, the lesion which is going below subcarinal and struggling and injuring some intrathoracic vessels, causing an emergency, better to do a sternotomy and do a plain surgery. Patient recovers within a week's time. So, and thank you, and I'm happy to take any questions, Dr. Poonam.
Thank you, Dr. Kannan. A very great lecture. I think it's a very unusual topic, which not many people are very well aware. One thing I would request all the attendants to please, whoever has attended, to please keep themselves muted, because it leads to a lot of confusion to the speaker. So humble request. So if there are any questions, we can take them. You can put it on chat box if there are any. So in your experience, Dr. Kannan, how common do you come across a case where you had to do a sternotomy or any other procedure other than this cervical approach? So how common do you do it, Dr. Kannan? Like
so on an average, most of the tumors which is above the aortic arch comes out from the neck. In our practice, at least 5% of the patients with retro-sternal extensions would need sternotomy.
So above the aortic arch.
For vascular control, we always do a sternotomy. We don't hesitate. If we have a thrombus which is going into the brachiocephalic vein, we'll do a sternotomy. If we have a thrombus which is going to the lower end of the IJV, we'll do a claviculotomy, get the control of the brachiocephalic vein, then proceed. So these are the two most important things.
Correct. So I think there is one question, Dr. Kannan. Sir, in level 7 mediastinal clearance, especially in medullary thyroid carcinoma, I think MTC, is there any difference in intraoperative technique or difficulty? In level 7 mediastinal clearance, especially in medullary thyroid cancer, is there any difference in intraoperative technique or difficulty? I think as compared to PTC, they want to ask.
For the PTC tumors, level 7, you trace runs along the trachea. Most of the nodes comes out from the neck. If it is medullary CA thyroid, the nodes which usually stud all along, so it would be involving it will involve the two right, two left also. So on the mediastinal classification, so we would do a sternotomy. We wouldn't hesitate. We would do a sternotomy more often in medullary CA thyroid when compared to PAP CA thyroid. So it would be little infiltrative as well. Medullary CA thyroid nodes would be infiltrative as well. We would like to have more space when we handle those necks, so that when we handle those nodes, so that we don't end up in intrathoracic emergency bleeding inside the thorax.
Yes, I think I agree with Dr. Kannan. Dr. Kannan said that medullary carcinoma patients will have more infiltrative kind of lymph nodes and there will be more need for a approach for sternotomy as compared to papillary carcinoma, right, Dr. Kannan?
Yes,
Because they
yes.
are easily removed. Even though
Removable.
we discussed that above the arch of the aorta or below the arch of aorta is going to be also important determinant for that. So how common do you think, Dr. Kannan, like what common complication do you think we can come across while doing that? I know that vascular injury is one of the most common cause, one of the most common sequelae. Is there any chances of injury to the like phrenic nerve, the vagus nerve, like neural injury? How common are they when we do a mediastinal approach thyroidectomy?
Okay. So when we do a mediastinal approach, if the lesion is extending in from the anterior compartment of the mediastinum into the other compartments, your dissection, when it goes blind, then it becomes difficult. So the phrenic, as you see in the neck, it is lateral to the internal jugular vein. When you have a lesion, similarly in the thorax, tilting towards right side or left side, then the chance of injury becomes more. When it is involving multiple compartments inside the mediastinum, better to do a sternotomy. The most of the injuries happen because of poor vision or blind surgeries. So if you open up the thorax, visualize things and then deliver it, most of the retrosternal goiters are non-infiltrative and they come out well. The chance of injuries diminishes very much. So most of the injuries which we talk about, like vascular injury or neural injury, occurs because of traction or blind dissection. So if it is under vision, then it becomes easier. If you do a sternotomy, you normally anticipate fewer like non-healing of the sternum in elderly or old people. You can develop smaller infections which are easy to handle. And there will be pleural injury. Most of these patients would need an intrathoracic drainage. On an average, the patients would need 7 days of a hospital stay to recover. On an average, 5 to 7 days if you do a sternotomy. So it is much safer to do a sternotomy than handling the neural injuries or vascular injuries post-operative.
Correct. So if there are any other questions, we can take them. Otherwise, we'll conclude the session. So if there are no more questions, now I would like to thank Dr. Kannan once again for a wonderful lecture. Thank you, Dr. Kannan. Thank you so much.
Thank you, Dr. Poonam. Thanks for having me here. Thank you.
Thank you.
దీంట్లో క్యాన్సర్ వచ్చిందండి. సో ఫీడ్స్ అయితే పైప్ నుంచి ఇచ్చుకోండి. సో ఇట్లాంటివన్నీ అంటే ఇంకా వెనుక భాగం నుంచి గొంతు మింగే ఓరోఫారింగ్స్ అన్నమాట. మింగే ఆస్పెక్ట్ ప్లస్ అంతా లారెక్స్ అంటే ఫస్ట్ రేడియేషన్ ఉంటుంది ట్రీట్మెంట్. సో రేడియేషన్ మొదలు తగ్గిపోతే ఏం సర్జరీ ఏమి ఉండదు. పోస్ట్ రేడియేషన్ ఏమైనా రెసిడెంట్ ట్యూమర్ ఉంటే సర్జరీ చేయాల్సి వస్తుంది. అర్థమైందా? సో రేడియేషన్ ఆంకాలజిస్ట్ నేను పంపిస్తాను.